The following podcast is part of a certified educational activity titled Breathing New Life into Treatment Approaches for COPD, the latest insights into the role of type 2 inflammation and targeted biologic therapy. Access the entire activity and complete the post-test at peerview.com/FPK860. Downloadable slides and practice aids are also available.
Hello, my name's Dave Singh. I'm a professor of respiratory medicine and clinical pharmacology at the University of Manchester in the UK. Welcome to this educational activity called Breathing New Life into Treatment Approaches for COPD. The latest insights into the role of type 2 inflammation and targeted biological therapy. So let me outline the goals for today. We have two here. First, we want to expand your knowledge of recent clinical data on emerging targeted biological therapy for COPD treatment. And second, we hope that this will equip you with strategies for applying the latest clinical evidence regarding these novel approaches to COPD treatment. So let's begin with some background on the heavy burden clinically of COPD. If you look at World Health Organization estimates, by 2060, there will be more than 5.4 million deaths per year attributable to COPD and coexisting conditions. Exacerbations are important events in the lifespan of a COPD patient, and they are linked to mortality. They also lead to a worse quality of life, which doesn't return to normal in many cases. There are more hospitalizations associated with exacerbations. And currently available management strategies don't effectively deal with this disease burden for many patients. I mentioned the link between exacerbations and mortality, and you can see it here on this graph. Patients with more exacerbations, whether we call them moderate events, which are worsenings requiring antibiotics and or oral corticosteroids that happen in the community, or severe events, which are hospitalizations, the more of these you have, the worse the prognosis. And hospitalizations, they give you the worst prognosis. So given this problem that patients have, high disease burden, exacerbations linked to mortality, there's a need for more effective strategies for management and pharmacological therapy. And this is where the concept of precision medicine comes in. Trying to identify individual groups of patients who are most likely to respond to a given therapy. And to do this, we need to think about the patient's phenotype and endotype. These words are often interchangeably used. I want to spend a few minutes explaining them because you'll see that they're quite different terminology. A clinical phenotype are the characteristics clinically that a patient has, whereas an endotype is the biology of the patient. And COPD being a complex disease with many components, often patients have multiple coexisting endotypes. A common example that brings this to life and is straightforward to understand is alpha-1 antitrypsin deficiency. It's a biological mechanism. You detect it with a biomarker, a blood test, and there can be a targeted therapy. So you need biomarkers to understand endotypes. And precision medicine is where you combine all the information you have, both clinical and biological, to come to the right treatment decision, identifying patients who are most likely to respond to a given therapy. So I want to spend a few minutes talking about inflammation in COPD with regard to biological mechanisms and endotypes. We've long understood that chronic airway smoking causes injury to the airway epithelium, and these cells then release cytokines and chemokines that amplify the innate immune response. The innate immune response is comprised principally of neutrophils and macrophages, and these cells are able to engulf the particulate matter from cigarette smoke, or whatever the cause of COPD is if it's due to particulate matter. For example, pollution will be another cause. Engulf the particles, and this really then is a host defense response against the harmful particulate injury. After years of chronic smoking, this innate immune response is permanently amplified, and so it carries on even if an individual stops smoking. So an abnormal innate immune response is something that all individuals with COPD have. What we've grown to understand in recent years is that some COPD patients also have an amplified type 2 response. There are a multitude of signaling molecules, cytokines involved in this. Interleukin 5 recruits eosinophils from the bone marrow and directs them towards tissue sites of inflammation. Interleukin 4 and interleukin 13 also play key roles in type 2 inflammation. And eosinophils are one of the common cells that can be used to identify patients who have type 2 inflammation. In recent years, we've also increased our understanding of the role of epithelial-derived alarmins. So these are cytokines released by epithelial cells in response to injury or danger signals, and they act as master coordinators of both type 2 and non-type 2 responses. So they broadly sit upstream and coordinate the subsequent activity of whole signaling pathways. Focusing then on type 2 inflammation, in different studies, depending on how you measure eosinophils, whether it's in sputum or blood, you generally find that between 20 to 40% of patients have evidence of type 2 inflammation, and this is associated with an increased risk of exacerbations. And this diagram from one of my publications shows a simplified view of blood eosinophil counts and their relationship to drug responses and clinical outcomes. So patients with higher blood eosinophil counts have more type 2 inflammation in the lungs. So blood eosinophil counts are acting as a biomarker to tell you about a profile of inflammation that the patient may have in the lungs. And those with higher counts have a better response to inhaled corticosteroids because inhaled corticosteroids address type 2 inflammation. And those with lower blood eosinophil counts have a disordered microbiome and tend to have more bacterial infections and a poor response to inhaled corticosteroids. So I mentioned the type 2 response in patients with higher blood eosinophil counts. This is a bronchoscopy study and sputum sampling showing a panel of type 2 cytokines that are increased in the lungs in patients with higher blood eosinophil counts. And one of the consistent cytokines that lit up in this study was interleukin 13, which is a driver of mucus hypersecretion, airway remodeling, and smooth muscle contraction. So it's important to understand the different roles that mediators of type 2 inflammation may play. I mentioned earlier that interleukin 5 has a pivotal role in eosinophil recruitment and differentiation and survival. Interleukin 4 and 13 signal through a common receptor. Interleukin 4 plays a role in T helper 2 differentiation and B cell isotype switching. I mentioned the roles of IL-13, but IL-13 is potentially one of the key drivers of mucus hypersecretion and airway remodeling. IL-4 and 13, by having a common receptor, do share many biological functions. So with this in mind, we've seen the evolution of a number of biologics shown on this slide that are targeted either at the type 2 response or higher up at alarmins, which then will target the type 2 response, but may also have efficacy beyond type 2 inflammation. For example, type 1 and type 17 inflammation. So focusing on biologics that target type 2 specifically, we have anti-IL-5 therapies, so mepolizumab and benralizumab, with the latter targeting the receptor, the form of the cytokine itself. We have Dupilumab, which targets the receptor for IL-4 and IL-13. And then we have anti-alarmins. The two that there are drugs against are TSLP and interleukin-33. So tezepelumab targets TSLP, and astegolimab and itepekimab target interleukin-33. So given the opportunity then that we now recognize that some patients have type 2 inflammation, if we reassess clinical practice, inhaled therapy, although successful for a subgroup of patients, for another subgroup of patients, despite having optimized inhaled therapy, they carry on having airflow limitation, a heavy burden of symptoms, and exacerbations. And amongst those patients who are on triple therapy, optimized standard of care, many have type 2 inflammation, which you can detect using eosinophil counts, and they continue to have exacerbations. And this gives us the opportunity to use novel treatments targeting type 2 inflammation. So I want to share with you now recent data from congresses this year, focusing a bit more on the European Respiratory Society 2024. But there was also data from the American Thoracic Society this year. And this data is on novel therapies, including the biologics I've already mentioned. So this is the NOTUS study. It's a randomized controlled trial over 1 year. It's a phase 3 study. There's a highly similar study called the BOREAS study, which was published in the New England Journal of Medicine in 2023. The NOTUS, same journal, published 2024 and shown first at the American Thoracic Society. Patients who were already on inhaled triple therapy with a history of chronic bronchitis and 2 or more exacerbations in the last year were recruited. They all needed to have evidence of type 2 inflammation. In other words, at screening, a blood eosinophil count more than 300. You can see that approximately 465 to 470 patients per arm were randomized Dupilumab versus placebo in addition to their usual inhaled therapy. The primary endpoint was moderate and severe exacerbations combined. So that's the data here. There was a 34% reduction in moderate or severe exacerbations with Dupilumab compared to placebo. You can see that in the bar graph, and then the cumulative number of events throughout the time course of the study with Dupilumab being lower. Because of the highly similar design of BOREAS and NOTUS, then the data could be pooled for greater statistical power to understand the benefit on exacerbations. And overall, then, we see a 31% reduction in exacerbations in this high-risk exacerbation population with type 2 inflammation. It's interesting to note that Dupilumab causes an increase in lung function, FEV1, that's observed very early on, so within 2 weeks of treatment. And it's sustained throughout the treatment period. And depending on which time point you look at, it's generally over 80 mils treatment difference. So this early and sustained improvement in lung function, coupled with the exacerbation prevention you saw on the previous slide, should mean that patients feel better. Here's an interesting analysis of the patients who had no exacerbations throughout the course of the study. So although they had exacerbations in the year before the study, those on Dupilumab or those on placebo, those with no exacerbations. And you can see here the overall population, and then the population who are called the non-exacerbators, and that's at the top. Remember, they all had exacerbations in the year before. And here we see an improvement in quality of life measured by the St. George's Respiratory Questionnaire, as expected in the overall population, but also in the non-exacerbators. And so here, that treatment difference is probably at least in part due to that lung function improvement that the patients with Dupilumab experience. And if you remember the roles of interleukin-13, probably, in my view, interleukin-13 is playing a key role here as it addresses airway remodeling, mucus hypersecretion, and smooth muscle hyperplasia and contraction. And targeting all of these mechanisms can improve airflow obstruction and may lead to the benefits that you see here. You've just seen on the last slide the St. George's Respiratory Questionnaire. Here we see a different way of measuring respiratory symptoms, patient-reported outcomes. It's the exact score. This is a daily diary that's collected electronically. You can see the total score, and then it's split into different domains. We have breathlessness, chest symptoms, and cough and sputum specifically. There's a significant benefit with Dupilumab for the total score, and interestingly, the breathlessness numerically seems to have, amongst the domains, the largest treatment difference. And that lends itself to the arguments that I advanced in the last couple of slides, that this improvement in lung function due to the mechanisms associated with IL-13 is contributing here to less breathlessness because of better airway physiology in those patients who receive Dupilumab. So let me move on to a different biologic. Remember, Dupilumab was targeting IL-4 and IL-13. Here's mepolizumab, which targets the cytokine interleukin-5 and therefore would be expected to decrease eosinophil numbers and then eosinophil recruitment into the lungs. Here's an analysis of a previous phase 3 study with mepolizumab in patients with a history of exacerbations. It's a post hoc analysis dividing the patients into those with and without symptoms of chronic bronchitis. You see different endpoints here. We have the rate of moderate or severe exacerbations, and it seems to be that the treatment effect is similar in both groups. However, for the CAT score, certainly, and perhaps for the St. George's score, there's perhaps a greater response with active treatment in those with chronic bronchitis. Now, this is a post hoc analysis. It's interesting, and for all post hoc analysis, they're really hypothesis generating and something that would need to be confirmed prospectively. Here's another post hoc analysis, and this concerns another anti-interleukin-5 modalities. This is benralizumab that targets the interleukin-5 receptor. It's a pooled analysis of two phase 3 studies, the Galathea and Terra Nova studies. Here we see patients who had an exacerbation after randomization. And it focuses on a particular subgroup, that those patients with the higher eosinophil counts, more than 300, who were previously on triple therapy and before study entry had 3 exacerbations in the last year. And this subgroup of interest seemed to be the one that throughout the course of the study had the biggest treatment response. This analysis looks at, in that potential responder subgroup, what happened after they had experienced their first exacerbation. So here we have 145 patients included, approximately equal numbers for benralizumab and placebo. And here we're really looking at the next exacerbation. And you can see here that there are fewer next exacerbations within 30 days, within 90 days in the active treatment group. And this gets us to thinking that one of the key mechanisms of benefit of a biologic might be preventing recurrent events. Patients might have a breakthrough, but then a biologic may still confer advantage in stopping the next event. Let's move on to Alarmin. So itepekimab targets interleukin-33. This is a phase 2 study, and an analysis, a subgroup analysis of that phase 2 study showed that former smokers seem to have a greater benefit of itepekimab treatment compared to current smokers. And there are biological reasons why that might be the case. Interleukin-33 itself appears to be more highly expressed in the epithelium of former smokers. So here's an analysis looking just at the former smokers and dividing them further into patients who had 3 exacerbations in the last year before study entry, and those 3 or more, and those who had exactly 2 in the year before study entry. Now, in these former smokers, you can see that itepekimab conferred approximately a 50% exacerbation rate reduction in both groups. So the exacerbation history, as divided here, in terms of percentage treatment effect, didn't make any difference, didn't have any influence. However, what was interesting, and you would expect this, is that the patients who had more exacerbations in the last year, 3 or more, had more during the study. So while the treatment effect is similar when you correct for the number of exacerbations, the overall burden of exacerbations, even during the study, is higher in those who had more exacerbations before the study, whether you were randomized to placebo or active. Here's tozorakimab. This is another anti-interleukin-33 treatment. The results of a phase 2 study, the Frontier 4 study, were released at the ERS. This is the first time they've been shown at a conference. And the primary endpoint was lung function. Now, many of the studies I've shown you so far have really focused on exacerbations, and they've been phase 3 studies. They're larger, they carry on over 1 year. Smaller phase 2 studies where you're looking for a signal of effect sometimes focus on different endpoints, such as FEV1, where you may see a signal in a shorter duration. Well, in the overall population, there was a small treatment effect of 24 mils that was not statistically significant. In pre-planned analysis to look at the patients who had 2 or more exacerbations in the last year, we see here that the treatment effect increases, and now it's over 60 mils of lung function benefit. Also, those with higher blood eosinophil counts, again, you see a bigger benefit on lung function. And the purpose of such a phase 2 study then can be to select the right population for phase 3. And here it seems to be those with more exacerbations are potentially those who have a bigger treatment benefit. Interestingly, in this study, there was also an analysis of mucus plugging, and it's an exploratory analysis, and there was data to support anti-interleukin-33 treatment reducing mucus production. It's a small phase 2 study, and that would need to be confirmed in a larger data set. The forest plot here concerns complex events. The study was not big enough or long enough to look properly at exacerbations. Complex events are a composite endpoint that encompass exacerbations and diary card worsenings. They serve as a surrogate for exacerbations. And here again, we see a signal, but not significant, of a 21% reduction in complex events. And again, when we refine for more exacerbations, we see a bigger effect. Interestingly, refining for eosinophil counts, unlike lung function, did not give a bigger effect. And perhaps, and maybe we should expect this, this suggests divergent roles for type 2 in lung function versus exacerbations with regard to alarmin signaling. And then we have TSLP, a different alarmin. Tezepelumab targets TSLP. Here are phase 2 data. Now, this phase 2 study was bigger and longer, so double the patients approximately compared to the Frontier study, and this was a 1-year study. Again, it's principally a study to find the population that you might then enroll into phase 3. And while the overall effect on exacerbations was a non-significant 17% exacerbation reduction, when you look at the pre-planned analysis of patients with over 150 eosinophils, over 300 eosinophils, you can see that the effect gets bigger and bigger, both on exacerbations and lung function. So while the primary endpoint here is negative, these other analyses point towards a potential subgroup who may be the target population in the precision medicine paradigm, those with exacerbation risk and higher eosinophils, and the cut point may be 150. And this was shown at the ERS then, showing the delay to first exacerbation, whether it's time to first moderate or severe, or time to first severe exacerbation. We can see hazard ratios of 0.8 and 0.7, the latter for time to first severe. Neither of these were statistically significant, but the point estimates point in the direction of a benefit that needs to be further studied. I mentioned astegolimab. This targets the ST2 receptor. It's the receptor for interleukin-33, and the phase 3 studies are ongoing. And of course, we all eagerly await the results of this. So let me provide a summary. With current inhaled therapies, there's a significant unmet need, particularly for exacerbation prevention. Many patients, despite receiving optimal standard of care, continue to exacerbate and have a heavy burden of symptoms. We now understand that these patients are heterogeneous. They vary from one another. And a subgroup have type 2 inflammation. And this gives us the opportunity to use targeted treatment to alleviate the burden of disease. We already have some biomarkers to help us understand who has type 2 inflammation, and there is a need to further develop more biomarkers to help stratify patients and understand which biologic from which patient. Now, Dupilumab has been approved for the treatment of COPD with type 2 inflammation since July 2024 in Europe. And now recently, the FDA has approved the use of Dupilumab in the US as well. The other biologics that you've seen are still in phase 3 studies, and of course, we all keenly await the results of these studies. So thank you for joining me today, and I hope you found the information useful and that the information here will help you continue to care for COPD patients in an effective manner.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Sanofi and Regeneron Pharmaceuticals. To access all materials for this activity, visit peerview.com/FPK860.